Welcome to another video by Phoenix Medical Lectures. In today's video, we'll be seeing about heart murmurs. So basically, there's this diagram here which shows all the possible conditions which cause the major heart murmurs. So that includes mitral regurgitation stenosis, tricuspid regurgitation stenosis, pulmonary stenosis regurgitation, aortic stenosis and regurgitation. This is about the valves. Apart from this, we have HOCM, which is hypertrophic obstructive cardiomyopathy, and something known as the ventricular septal defect, coarctation of aorta, and patent ductus arteriosus. These are the major conditions that we're going to see. So, heart murmurs, we normally express the blood flow by something known as the Reynolds number. So there's an increase in the Reynolds number means that there's an increased turbulent blood flow. So increased turbulent blood flow normally leads to an increased intensity of the murmur. So what are the causes of heart murmurs? So first one is an increase in velocity. Okay, there'll be an increase in velocity that will increase the Reynolds number. So, and then there'll be a decrease in viscosity that will increase the Reynolds number. And then there is a blood flow through incompetent valves. That is important because in this condition is where we see about all the regurgitation and stenosis of the valves. So, in velocity increase, there's two different causes. One is increase in contractile strength, which is basically an increase in the contractility, and a decrease in diameter can also cause an increase in the velocity. So we'll see all the causes in detail. So when there is a decrease in diameter, so there are various conditions we're going to see wherein there'll be a decrease in the diameter which will cause an increase in velocity, in turn increase in Reynolds number, in turn an increase in the turbulent blood flow leading to an increase in the intensity of the murmurs. So first we're going to see about ventricular septal defect. In this, actually the blood should be going into the aorta. But since there's a defect here, blood is going to enter into the right ventricle from the left ventricle. So when there is a smaller VSD, there's going to be an increase in the velocity. So there'll be an increase in turbulence and an increase in the murmur. Coming to coarctation of aorta again, so there's a defect here. Coarctation of aorta, there's a decrease in the diameter here. So that is also going to cause increase in velocity. Coming to aortic stenosis here, where there is a decrease in the diameter. Again, that is going to cause an increase in the velocity. Hypertrophic obstructive cardiomyopathy also, right here, there is going to be an obstruction in the flow, and that is like what? A decrease in the diameter. So again, an increase in the velocity. So that was about a decrease in diameter causing increase in velocity. What was the second cause? The second cause was an increase in the contractile strength. So basically the contractile strength is going to increase when there is an increase in force. That increase in force is going to cause an increase in velocity, thereby, increasing the intensity of the murmur. So what are the conditions that are going to cause an increase in the contractile strength? That will be the hyperdynamic heart. So what are the causes of a hyperdynamic heart? We divide it into three. One is sympathetic nervous system. So basically exercise, fever, sepsis, and increase in the thyroid hormones are going to cause. Second, increase in volume. For example, in pregnancy. And then high output states like anemia, beriberi, and beriberi is basically vitamin B1 deficiency, and then atrioventricular fistula. These are all going to cause a increase in contractility, thereby causing an increased intensity of the murmur. Third one is a decrease in viscosity. So in anemia, basically we see a decrease in viscosity, so thereby an increase in turbulence, and that will lead to a increase in murmur. Finally, we're going to see something known as passage of blood through incompetent valves. Incompetent valves normally lead to regurgitation of blood, like backflow of blood from the place that it comes from. So there we basically have four valves: aortic, pulmonary, mitral, and tricuspid. So all regurgitations is the fourth one. So what is the location? So we know there is a murmur. So where do we listen for it? So there are basically 5 locations that we're going to see, which is aortic valve, pulmonary, Erb's point, tricuspid, and mitral. So first, coming to aortic. Aortic is in the right second intercostal space. Right second intercostal space. So there we can listen for aortic stenosis murmur, aortic regurgitation murmur, and coarctation of aorta murmur. Coming to pulmonary, it is in just the opposite, left second intercostal space. Therefore, again, pulmonary stenosis, pulmonary regurgitation. Apart from that, atrial septal defect. Coming to Erb's point. Erb's point is just below the pulmonary location, that is in the left third intercostal space. So there we overall hear all the sounds, basic heart sounds like S1, S2, and hypertrophic obstructive cardiomyopathy. Then tricuspid valve, that is in the left fourth intercostal space. So all of these are parasternal. In the left fourth intercostal space, we listen for tricuspid stenosis, tricuspid regurgitation, and ventricular septal defect. Finally, coming to the mitral valve. Mitral valve, there's some just a basic difference, that it is in the left fifth intercostal space. But the difference is it is in the mid clavicular line. It is basically half an inch medial to the mid clavicular line. That's where we listen for mitral valve, and there we listen for mitral stenosis, regurgitation, and mitral valve prolapse murmurs. Okay, so these murmurs, they have the tendency to radiate. Certain murmurs have the tendency to radiate, like aortic stenosis radiates to the carotids, aortic regurgitation radiates to the left upper sternal border, and mitral regurgitation radiates to the axilla. What is the quality? So basically all regurgitative murmurs, like most regurgitative murmurs, have a blowing sound, which is like, it is not rough, it is musical. Whereas the stenosis murmurs are having a rough rumbling murmur. And there's something known as a machine-like murmur which occurs in the patent ductus arteriosus, which is basically a connection between the pulmonary artery and the aorta. Okay, coming to quality. Quality is basically equal to pitch. So why do we need to look for what is the pitch of the murmur? That is because we need to decide whether it is going to be heard better with the diaphragm of the stethoscope or better with the bell of the stethoscope. So first is ventricular septal defect. There's an increase in, whenever there's an increase in pressure gradient, that is going to cause high pitched sounds. Whenever there's a decrease in pressure gradient, that is going to cause a low pitched sounds. So increase in pressure gradient, high pitch, and we are going to use a diaphragm. Mitral stenosis, increase in blood flow, decrease in pressure gradient, so a low pitched, so bell of stethoscope. Aortic stenosis, increased pressure, high pitch, diaphragm. Coming to intensity, we basically grade the intensity into 6 different grades. So the first grade is there is difficulty to discern the murmurs, we can't hear it. Second is it is difficult to hear, it is faintly heard. And then there's third, where we can easily hear the murmur, and then 4 wherein it's heard and it's felt also. So that a thrill is something known as a palpable murmur, so you can feel it. And then 5th one is it is heard, it is palpable, and we keep the stet barely on the chest and still we can hear the murmur. Coming to the 6th one, it is just the same, except that we can just hover on the chest and we can still hear the murmur. So what is the clinical correlation of the grading? So basically less than 3 grades will be like mostly benign conditions, and more than 3 will be pathological conditions. So what is the exception to the rule? It is ventricular septal defect. So when there's a little mild defect, that is going to lead to a high intensity murmur, but when there's a bigger defect, that is going to lead to a lower intensity murmur, so that can be misleading. So what is the timing and configuration of the murmur? So the timing is divided into systolic, diastolic, and continuous. So we'll see everything. Systolic is also having sub classifications. So first we'll see about the early systolic murmurs. What all causes early systolic murmurs? That will be aortic stenosis, pulmonary stenosis, hypertrophic obstructive cardiomyopathy, and coarctation of the aorta. These are all going to cause early systolic murmurs. So aortic stenosis will have a characteristic ejection click. So that's the opening of the aortic valve. So there's an ejection click, and then there'll be a crescendo decrescendo murmur, which basically means there's going to be a sudden flush of blood inside, and the blood flow is going to reduce slowly. So there'll be like an increase in the volume, and then slowly it's going to come down. So this is heard in the aortic valve region, yes, because it is aortic stenosis. So it is heard in the right second intercostal space. Next one is hypertrophic obstructive cardiomyopathy that does not have an ejection click, but it also is like a crescendo decrescendo murmur, and that is heard in the Erb's point, which is left third intercostal space. Coarctation of aorta. This is kind of different. It is heard in the left posterior hemithorax. Okay, so coarctation of aorta. So we saw about early systolic murmurs. Coming to mid systolic murmurs, mitral valve prolapse. This also has an ejection click, but the difference is that the ejection click in aortic stenosis is going to be immediately once the systole starts, but this is going to come a little bit later. So ejection click, and then we have a mid systolic murmur for mitral valve prolapse. So basically in MVP, there'll be a weak mitral valve leaflets and also chorda tendineae that will also be weak. Okay, so mitral valve region, it is in the left fifth intercostal space, half an inch medial to the midclavicular line. This will radiate to the axilla. Apart from this is something known as the physiological or functional murmurs. So hyperdynamic states that we already saw, like fever, sepsis, increased thyroid hormones, exercise, pregnancy, vitamin B1 deficiency, AV fistula, and anemia. These all cause mid-systolic murmurs. Coming to Still's murmur, that is that occurs in pediatric age. It is also a mid-systolic murmur, which is a benign condition. So grade 1 to 2, there'll be an increase in intensity if there's increased venous return, like squatting, lying flat, and raising a leg. And then the intensity is decreased in decreased venous return when standing up quickly. Okay, that was about mid-systolic murmur. Now coming to holosystolic murmur. Holosystolic murmur is a murmur that exists in the entirety of the systole. So for that, we have mitral regurgitation, tricuspid regurgitation. In mitral regurgitation and tricuspid regurgitation, there's going to be a holosystolic murmur. And in MR is going to be in the left fifth intercostal space, whereas tricuspid regurgitation in the left fourth intercostal space. And we already saw regurgitations are normally musical sounds or blowing sounds. So blowing sounds. Coming to ventricular septal defect, that is in the left fourth intercostal space, parasternal tricuspid area. So that is going to be harsh and rough. So this is already we saw there's a smaller VSD, intensity is going to be high. If there's a larger VSD, intensity is going to be low. Okay. That was about the systolic murmurs. Coming to diastolic murmurs. Diastolic murmurs is when it comes from starts with S2. Okay, S2 to S1. So first thing we're going to see is aortic regurgitation or pulmonary regurgitation. This is a decrescendo murmur. So earlier the volume is going to be high. The regurgitation volume is going to be high, and then later on the volume will reduce. So that's the reason for the decrescendo murmur. So this is heard in the right second intercostal space because aortic is heard in the right second, pulmonary is heard in the left second. And this aortic regurgitation murmur radiates to the left second intercostal space also. And it is a blowing sound since it's a regurgitation. Okay, coming to stenosis, again similar, but there's a little bit difference, which is opening snap that occurs in the stenosis. So again, this is about opening the valve. Where we had ejection click there, we have an opening snap here. And this is heard, mitral stenosis, it's heard at the left fifth intercostal space, half an inch medial to the midclavicular line. And tricuspid is heard in the left fourth intercostal space, parasternal region. So this will be rough and it'll be rumbling, rough rumbling. This is a stenotic condition. Okay, that was about diastolic. Coming to continuous murmurs. Continuous murmurs, the main example will be patent ductus arteriosus, wherein there will be more pressure in the aorta than in the pulmonary artery. So, what will happen? There will be a constant shunt between the aorta and the pulmonary artery. So, from S1 to the next S1, we hear a murmur. So that is the continuous murmur. There's no like systolic, diastolic, both systolic and diastolic we hear the murmur. So this is normally heard in the left infraclavicular region, and this is machine-like sound. We already saw patent ductus arteriosus is gonna sound like a machine sound. So what is the differential diagnosis of patent ductus arteriosus murmur is something known as a cervical venous hum. So here, this is normally heard in the right infraclavicular region, but this might also be heard in the left infraclavicular region. So to differentiate, we normally ask to flex the neck. That will decrease the intensity of the murmur. So it basically reduces the blood flow from the jugulars. That's why there's a decrease in intensity. So coming to the murmur accentuation. So accentuation of the murmur first by inspiration. So in inspiration, what happens? There'll be a decrease in the intrathoracic pressure. That will lead to an increase in venous return. When there's a decrease in intrathoracic pressure, there's going to be an increase in the venous return, and the vice versa. So inspiration in tricuspid stenosis and regurgitation, pulmonary stenosis and pulmonary regurgitation, we are going to see the what is going to happen in this. So there'll be an increase in the right ventricular filling, and so there'll be an increased intensity of the right-sided murmurs. What are the right-sided murmurs? The ones that we saw here, tricuspid and pulmonary. So that's the reason there'll be an increase in the right-sided murmurs. In expiration, it's just the opposite. Increase in intrathoracic pressure, decrease in venous return. Left-sided filling is going to be more, and so left-sided murmurs will increase. What are the left-sided murmurs? Mitral stenosis regurgitation, aortic stenosis regurgitation. Next, in leaning forward position, we saw inspiration, we saw expiration. Now leaning forward position. So this will bring the aorta and the aortic valve closer to the chest wall. So that is going to increase the intensity of these murmurs like AS, AR. Apart from that, HOCM and coarctation of aorta. What about left lateral position? If someone's in the left lateral position, the mitral valve is going to get closer to the chest wall. So that is going to lead to increased intensity of MR, MS and mitral valve prolapse murmurs. Okay, if someone's squatting, so what happens? There'll be an increase in the venous return. That will in turn increase the preload. That will increase the stroke volume, and that will increase the intensity of all murmurs. But there are a few exceptions, which is two main exceptions, which is hypertrophic obstructive cardiomyopathy, which is when a person squats. That will increase the left ventricular end diastolic volume. So what happens when that end diastolic volume increases? The obstruction is going to be relieved. So there'll be more area for the blood to flow. So if there's more area for the blood to flow, then the intensity of murmur is definitely going to decrease. So in HOCM, the intensity will decrease. Again, in mitral valve prolapse, what will happen? We already saw it is going to give an ejection click. This ejection click will come later because there's going to be more volume. The end diastolic volume is going to be more. So that is going to cause the click to come later. For the mitral valve prolapse, click to come later, and that is going to in turn lead to a shorter murmur. So there's going to be a later ejection click and a shorter murmur that we see here. Okay, so two exceptions. Okay, next coming to Valsalva maneuver, it is somewhat similar to what we saw in squatting, because in squatting we saw that the intrathoracic pressure is going to decrease. So that is going to increase the venous return. But here, intrathoracic pressure is going to increase. So that is going to decrease the venous return. So if there is a decreased venous return, decreased preload, decreased stroke volume. So if the blood that is going to go out is going to reduce, there is going to be a decreased intensity of all the murmurs. There it was increase in intensity of all murmurs. Here it is a decreased intensity of all murmurs. Again, it has two exceptions, which is the same. There also we saw hypertrophic obstructive cardiomyopathy and mitral valve prolapse. Here also hypertrophic obstructive cardiomyopathy and mitral valve prolapse. So what is the difference? Here, since the venous return has decreased and the left ventricular end diastolic volume has also decreased, So what will happen? The outflow obstruction will increase. The obstruction increases, then the intensity of murmur is definitely going to increase. Coming to mitral valve prolapse, you can see the difference here. The ejection click is going to be sooner because there is going to be less left ventricular end diastolic volume. So the ejection click is going to be sooner, so there will be a longer murmur. So these are the exceptions. Okay. So coming to hand grip, here what happens, the systemic vascular resistance is going to increase. So that is going to in turn increase the afterload. When someone grips their hand hard, it's going to increase the systemic vascular resistance, in turn increasing the afterload. That will in turn decrease the stroke volume. So we are going to see 4 conditions where, so basically the stroke volume is decreased and there's going to be more blood in the ventricles. If there is more blood in the ventricles, then that is going to majorly cause changes in these murmurs. So first is aortic stenosis. So blood flow through the stenosed valve is going to decrease, right? So if it's going to decrease, then of course the intensity of the murmur is also going to decrease. So in aortic stenosis, the intensity of murmur is going to decrease in hand grip. Coming to hypertrophic obstructive cardiomyopathy, there's an increased blood in the ventricles. So that increased blood in the ventricles will lead to a decrease in the outflow obstruction. If there is a decrease in the outflow obstruction, the murmur intensity is also going to reduce. Coming to mitral valve prolapse, again the blood in the ventricles is decreased, so the click will definitely come later because the blood in the ventricle is increased. So if the blood in the ventricles has increased, that is going to cause the click to come later, and that is going to lead to the murmur being shorter. So that is a change that's going to happen in the mitral valve prolapse. Coming to mitral regurgitation, there's an increase in blood. Again, the same thing. There's going to be an increased blood in the ventricles. So that will lead to increased blood that is going to regurgitate. So that will cause an increase in intensity. So basically these 3, they'll be decreased. Only in MR it's going to increase, and a special condition AR, aortic regurgitation, wherein in hand grip there's going to be an increased systemic vascular resistance. We already saw that, but if there is an increase in systemic vascular resistance, that's going to cause a reduce in stroke volume. That was the major reason for all of those other diseases that we saw. Here there's an increase in aortic pressure. So there's an increase in aortic pressure that's going to increase the backflow. So that is going to increase the afterload. So that will increase the intensity of murmurs in aortic regurgitation. There's going to be more blood that is flowing back into the left ventricle. So coming to amyl nitrite. So this is the last thing we're going to see. Amyl nitrite is a vasodilator. So hand grip is going to cause vasoconstriction, and amyl nitrite is a vasodilator. So it's just the opposite. Exactly what we saw for hand grip, we're going to see just the opposite for this. So aortic stenosis, there we saw aortic stenosis, hypertrophic obstructive cardiomyopathy, and mitral valve prolapse having a lesser intensity. So here aortic stenosis is going to have a more intensity. So here we saw decreased blood flow through stenosed valve. There it is going to be increased blood flow in the stenotic valve. So that is going to cause an increase in the intensity. Here we saw an increased blood in the ventricles, like the left ventricular end diastolic volume is going to be high here, but there it is going to be low. So that is going to cause an increase in the intensity of the murmur. So just the opposite of what we saw here. So in mitral valve prolapse, we saw that in hand grip, when a person grips their hand, the click is going to come later and the murmur is going to be shorter. But here in amyl nitrite, when vasodilation occurs, so there'll be a click that comes early and murmur will be longer. Mitral regurgitation, there was increase in intensity there, there's a decrease in intensity here. And aortic regurgitation also, there was a increase in intensity of murmurs because there's increase in backflow, but that is not going to happen here. So this, it is going to be a decrease in the intensity of the murmur. Thank you.